Hello, my name is Dr. Charles Weaver. I am a medical oncologist and the founder and publisher of Cancer Connect. I want to thank you for joining us today for a live web chat with Dr. Andrea Pusic from Memorial Sloan Kettering Cancer Center on making informed decisions about reconstruction after breast cancer surgery. Dr. Pusic is a plastic surgeon who specializes in reconstruction after cancer surgery. She performs a broad range of reconstructive surgeries using a variety of state-of-the-art techniques. Dr. Pusic has a strong interest in breast reconstruction and is involved in a number of advocacy, outreach, and education initiatives for breast cancer survivors. During today's program, you will have the opportunity to submit questions. Just type in your question in the space provided below on the screen. Dr. Pusic will answer as many questions as possible in the time allotted following her presentation. I will now turn the presentation over to Dr. Pusic.
Welcome and good evening. I'm Dr. Andrea Pusic, and I'm a plastic surgeon at Memorial Sloan Kettering Cancer Center. I'm very pleased to be here with you this evening to talk about options for breast reconstruction. The first thing to know is that breast reconstruction has some very important benefits for women. And so in my own practice, what I hear women tell me is that having breast reconstruction just helps them feel more normal, to get back to normal life, to feel just like other women, to put this all behind them. And so that's really the key benefit of breast reconstruction from a body image perspective, just really even from a practical perspective for many women. It's just to avoid a prosthesis even, so allow us to wear the clothing that we like to wear, our bikinis, our bras, those kinds of things. So there are some very important benefits to breast reconstruction. The other key thing to know is that most women are now candidates for breast reconstruction. This wasn't necessarily always the case, but it is now. And so in your discussions with your doctor, with your plastic surgeon, your oncologic surgeon, there'll be discussions about what type of reconstruction you might be a candidate for, but almost all women are candidates for some approach. It may not be, I'll talk about the timing in terms of whether it can be performed immediately or not, but there are options. With talking to your doctor, you'll talk about medical risks. So patients say that have diabetes or heavy smokers might be encouraged to have a delayed reconstruction or not have reconstruction at the same time as their mastectomy, but at a later date to make it just safer, or once they've been able to quit smoking. Patients who've had previous radiation, we know increases the risk of certain complications, since they may be encouraged in a certain direction in terms of the approach to reconstruction. And I'll talk more about that in terms of as we work our way through the different options for reconstruction. Patients with different body types, so slender patients that may be encouraged towards different approaches compared to a more heavy-set woman. And then also we talk about, in the consultation process, the implications of disease stage and what a patient's individual motivations and goals are. So what are the most important things to an individual patient? What matters most to you? What are you hoping to achieve? And so in a consultation with a plastic surgeon, these are all the things that would be discussed. So there's no one option that is right for all women. There's not one option that's absolutely best in all situations, but understanding your options and understanding the different ways that reconstruction can be done and the different options for timing, that's the right thing for all women. So here are some photos on the left. Here you'll see a patient who's had immediate reconstruction, and here's a delayed reconstruction patient. And so both these patients have had nice reconstructions, but what you'll see here is this is the increased scarring because of the delayed reconstruction. So we've had to remove some of the previous skin and add the abdominal tissue for this reconstruction. So in general terms, one of the key benefits of immediate reconstruction would be decreased scarring on the breast. And here's another example of this. Here's a patient this is another patient who's had reconstruction using her lower abdominal tissue. And here we see the previous scar. And the reason the scars in this particular patient and the other previous is that these patients had also had radiation. So in particular, we've had radiation after the mastectomy and a delayed reconstruction, it means that we may then have to remove some additional skin, which means that these scars have to be moved up higher on the breast, which for clothing and low-cut tops, that's certainly an issue for women. So there's essentially sort of three main approaches to reconstruction. What I'd like to do now is work you through each one of these different options. So there's using a patient's own tissue, and so in most cases that means using the lower abdominal tissue. There's using breast implants, and we'll talk through the timing and different stages of that. And then there's a combination of using implants in your own tissue, which is most commonly what we call a latissimus dorsi flap, taking tissue from the back area and combining that with an implant. So let's talk first about using your own tissue. And I'm going to focus for this evening on using your own tissue, taking tissue from the lower abdomen. There are other approaches, but just in the interest of time this evening, I want to focus on lower abdomen. And so what you see here is a patient, and she's had reconstruction of both breasts. This is the tummy tissue that's been taken to reconstruct both breasts. And so just to show you a little bit what that looks like, this is where an incision would be made through here, and essentially it's all this tissue here that is removed, it's divided, and it comes up to make the two breasts. So really, in terms of making a breast that looks and feels most like a natural breast, using your own tissue really is superior in that setting. For patients who've had previous radiation, it's also a further advantage because sometimes, not always, but in some cases with some of the other approaches like implant reconstruction, scar tissue would form. So for patients who've had radiation, particularly a mastectomy and delayed reconstruction, then really using your lower abdominal tissue is a great way to go. It's useful in women who are a little bit overweight and would like to get rid of that lower tummy tissue. The scars, to some extent, do look like a tummy tuck, but it is important to note that they're a little bit higher sometimes, and the tummy closure can be a little bit tighter than it might be in a traditional tummy tuck per se. It's useful for large-breasted women. And it's also particularly good for women who are having one breast removed, because with using your own tissue, that's really where we get the best match to the other breast. You can imagine that for a woman who's having implants, then it's implant to implant. But when a woman's keeping one breast and having a mastectomy reconstruction on the other, then keeping her own tissues, using her own tissue for that reconstruction really does give us the best match. And that tends to be the best match over time. And as we go through, I'm going to show you also some research data that shows that that's what women are telling us, is that over the long term, when you're having one breast removed and keeping your own breast, that's really where the symmetry is best, and it also, the match stays best over the longer term. So how do we do that? There's a couple of different ways. Traditionally and historically, this is how it was designed, was called a pedicle tram. I'll just walk you through a little bit here. Again, this would be the incisions here just above the belly button, an incision going down here. And so it's essentially this tissue, and say in this patient we're doing a unilateral reconstruction, so it's this tissue comes up, and the blood supply is coming from this muscle here. This is the rectus muscle. It has a blood vessel that runs through it, and so it's essentially rotated up to create the breast. And here we would actually take off a little bit of this tissue. This would be, we would throw away, and the rest would be buried in here, and this would create the breast mound. What we do, it comes down to here, and that's why there's just the one incision here. This is that, and then the belly button stays where it is, and we pull this down, and then we make a little opening, and then we bring the belly button out through that. So women can expect a scar on the lower abdomen here, and then also a circular scar around the belly button. So this is called a pedicle flap, and basically the blood supply is coming in this direction. More and more what we're doing also now is a different approach, the same tissue being brought up, but in terms of how it's actually transferred from the abdomen, it's called deep flap reconstruction. So you'll hear different terms. You'll hear free flap reconstruction, deep or DIEP reconstruction, or muscle-sparing free trams is another term, and I'll just explain what all that means to you. But the whole evolution of these different techniques to reconstruction was to try to minimize the potential negative impact on the abdomen. So if you think about when we do a pedicle flap, to get that blood supply, we're taking the entire rectus muscle, which is one of many of different muscles in the abdomen, but it is requiring taking a little more muscle. The deep flap evolved for the effort to try and decrease the amount of muscle and the potential risk of abdominal weakness or hernia. And so what we do here is we take the blood vessels down in the bottom here, and we dissect them through the muscle. So instead of relying on blood supply coming from the top, we're taking the blood supply from the bottom, and we dissect it through where the blood vessels come through the muscle here, and then that is how we transfer the tissue up. So that, I'll go back here, so this really, instead of harvesting that whole muscle, we're keeping that in place and transferring the tissue up. So that's primarily our approach to reconstruction from the lower abdomen now at Sloan Kettering. But I would say also is that for women who are talking to plastic surgeons elsewhere in the country or looking at different options, that the pedicle tram flap is also still a very good option. One of the benefits of a pedicle flap is it's actually a little bit of a shorter operation. It can be done in 3-4 hours, whereas the free flap reconstruction, where we have to go under the microscope to do this hookup of the blood vessels, takes longer. So to do one breast using a deep flap reconstruction would be more like 4 to 6 hours. And it also needs to be performed in specialized microsurgical centers, whereas the pedicle flap can be performed in a more general environment. So going from there in terms of what are the potential problems or what are the potential issues with either TRAM or deep flap reconstruction. So any tissue transfer from the lower abdomen. As I said, the longer surgery, and I said longer surgery compared to, say, implant reconstruction. So 3 to 4 or 4 to 6 hours, depending on the approach to tissue transfer, in comparison to implant reconstructions, which can be 1 to 2 hour surgeries. A longer recovery when we're using your own tissue. So women generally ask me, when can I get back to work? When can I, how long is the recovery? When you're taking tissue from your lower abdomen, it's more like 4 to 6 weeks. Some women will be able to return to work at 4 weeks, depending on what kind of work they do, but some women will require a longer period of time, so it's certainly a consideration. One of the potential complications of flap transfer is the thing called flap loss, which is basically a loss of blood flow. So thinking about where we've hooked up those little blood vessels in the chest, and that's one of the, in terms of deep flaps compared to pedicle flaps, is that deep flaps, there is a 2 to 3% chance that in that first few days after the surgery, a little blood clot could form in those little vessels, and if that happens, then there's this chance that the operation simply isn't successful. That's why women are generally in the hospital for the first few days, so that if there's any problem with the circulation, that we can go back to the operating room and address that. Abdominal problems, and hence this is the progression from pedicle flaps to deep flaps. Women can develop fluid collection, which is a seroma, hernia or bulge, or just abdominal weakness or pain or discomfort. And so that's really a difference in terms of any operations that involve the abdomen. These things can happen. I would say overall, it's about a 10% chance of having some issues with your abdomen. And I think that's one of the downsides to using lower abdominal tissue. A lot of those problems, however, do improve over time. So women might notice something for the first several months, but say a little bit of discomfort or a feeling of tightness, but that would resolve at 6 months to a year. And then, as I said, the more noticeable scars. And I'll show you some examples now of what those scars look like. So going back to the issue around what might be best to match a natural breast, using your own tissue, and here's a woman who's had, here we have her TRAM flap reconstruction. Here's her natural breast, and you can really see that the contour matches the other breast very nicely, which is a little bit different than if she had an implant reconstruction, which would have more fullness up in this upper part of the breast. Here's another example of a patient here. This is her before her mastectomy surgery. She's had a biopsy. And then here we did a nipple-sparing mastectomy, and we reconstructed with tissue from her lower abdomen. And you can see in this patient, she's actually relatively slender, but because we were reconstructing a relatively small breast, then she was a good candidate still for having a deep flap reconstruction. Here's another woman. This is delayed reconstruction. I think she still has a really lovely breast shape. Here's that scar that I talked about where we've had to remove more of the skin. This is the lower abdominal skin. And then here, she did not have a nipple-sparing operation, but we've done nipple reconstruction to match the other side. What she's also had done is a reduction of the other breast to help match the size and also the shape of the reconstructed breast. And this is something commonly women will have done, maybe not at the same time as their initial mastectomy and reconstruction surgery, but 3 to 6 months later, and often done at the same time as the nipple areola reconstruction. I mentioned about the scars, and you'll see here on the top, there's a patient here, and here she's just had her deep flap reconstruction relatively recently. She's had her nipple reconstruction, and here she's had a reduction on the other side. And so these are the scars for the reduction, the lift on the other side. And so patients often ask me about the scars. It's very, very much a concern, and I think it is a very valid concern. But it's also important to note that these scars do fade over time. They never go away completely. But here you can see now this is 4 years later. And you can see the match over time has stayed really very good, and the scars have faded significantly. Still present, but have definitely faded. And so that's an important consideration when you're thinking about the pros and cons of different approaches to reconstruction. So let's talk about implants now. So implant reconstruction is generally performed as a staged approach. And so traditionally what we would do is put a tissue expander in. And I'll show you what that looks like. Basically a tissue expander is like a breast implant that goes in empty. It starts the process for us. Then the second phase, so here's a woman here, she's before her mastectomy. Here's the tissue expander that went in, and now she's been fully expanded. So the skin and the underlying muscles have been stretched up to accommodate the implant that we placed. In this patient, she actually desired to be a little bit larger. And so what we did here, as you can see on the other side, at the same time that we took out the tissue expander, I put in a breast implant, and so that's her final result. The other thing that, and then she subsequently also you can see she's had nipple reconstruction. Some of the things that we're doing that are newer now is we're seeing that some patients can actually have their breast implant put right in at the same time as the mastectomy. I'll talk a little bit about who are good candidates for that. That's called direct-to-implant reconstruction. And then more and more women are also having a nipple-sparing mastectomy. So instead of having their nipple areola area removed and reconstruction done later, they're now having that preserved, and then and that actually also facilitates direct implant placement. So here's tissue expander reconstruction, how it works. What we do is the tissue expander comes in here. It goes actually under the muscle, a little bit under the pectoralis. This is the serratus muscle. It's a finger-like muscle. And we just elevate a little bit of the edge so that it makes a nice little pocket in which the tissue expander is protected from movement. It doesn't move around. It also helps to protect against infection because the muscle helps provide an extra barrier and good blood supply. And then that expander, we gradually stretch that up over time, and then it's removed and the final implant is placed. All of that working through the same incision. So what are the benefits of implant reconstruction? Well, certainly shorter surgeries. Tissue expander placement takes about 45 minutes in addition to the mastectomy surgery. In the operating room, basically the recovery is very much the same as if you were having a mastectomy. A patient having a mastectomy may stay in hospital overnight, and a tissue expander placement would be the same. So shorter operating room times and a shorter hospital stay in comparison to using your own tissue. It's also a shorter recovery. Most women who have had a mastectomy and tissue expander placement could return to work or feel that they were well on their way to recovery more at 2 to 4 weeks than, say, the 4 to 6 weeks for using your lower abdominal tissue. It's particularly a good option to keep other options open for reconstruction. And then another thing is in terms of symmetry when we're reconstructing both breasts. And this is really the patient group that does best with implant reconstruction. Is the patient that's having both breasts removed either for cancer reasons or risk-reducing surgery. And as you can see here, that we have a really nice match, and that match is well preserved over time. But implant reconstruction does have some disadvantages in comparison to using your own tissue. I think, and I'll talk a little bit about our breast Q research that we do, but what women tell us is it doesn't feel quite as natural, quite as normal to the touch as using your own tissue, but it can look and feel great. One of the longer term issues is that both short and longer term is infection. The highest risk of having an infection with an implant reconstruction would be in the first 6 weeks, and that risk is still in about the 3 to 5% risk range. So most women will do absolutely fine, but it is a consideration, and it's probably the most common reason that we would either admit a patient back into hospital for antibiotics, or even in the worst case scenario have to remove a device and start the process again. There's a maintenance component to breast implants, so implants leak at a rate of about 1% per year, and so the recommendation currently, particularly with silicone implants, is that we consider imaging studies about every between 2 and 5 years, and then generally with silicone implants we'll actually change them about every 10 years. But that's a discussion that we would have on a one-on-one basis with patients. The implant changing and aging with the patient, this really talks about, this is the issue about keeping your own breast on one side and having an implant reconstruction on the other side. That if a woman gains weight or loses weight, or the other breast changes shape, droops a little bit over time, the implant reconstruction may not keep up with that, and that's a disadvantage. And then finally, scar tissue can form around implants. By that, what I mean, we call it capsular contractions, your body's just tightening up around the implant. And so there's a normal process where there's a little capsule around the breast implant, but in women who have what we call capsular contracture, that scar tissue is really tightening up around that. For some women, they may develop that and it's barely noticeable. Other women will experience some discomfort, or the breast won't look as nice as it used to. And if that occurs, then we can go back to the operating room, we can release the scar tissue and change the implant. So here's some photos of patients having breast implant reconstruction, and so the ideal candidate would be a slender patient who's having both breasts removed. And you can see here, this patient wanted to be just a little bit larger, and so you can see here there's before her surgery and after her surgery. Her mastectomy incisions are just along the side here, and she's putting on some special tapes to help minimize the scarring and to help the scars fade. Here's another patient who had smaller breasts and wished to be a little bit larger, and she's also had a nipple-sparing mastectomy. So for her, this was a great benefit. And again, going back to that ideal candidate, a patient who's slender, having having both breasts removed. And my patients that I see that have had this, the stability, there's great stability of the results. I see patients year after year. I saw a patient today who's pregnant with her second child after having had her mastectomies before she even started her family, and she looks great, and she's looked great all through these last 8 years of having her children. And then finally, the newest thing in terms of implant reconstruction is direct-to-implant placement. And so increasingly now, as we're doing more nipple-sparing mastectomies, meaning that no skin is removed, we're just essentially scooping out the breast tissue, and the skin envelope, all of this is left intact. That's facilitated, so all this skin is left intact and just the breast tissue is removed. That's really facilitated us being able to avoid the tissue expander phase. And so in this patient, this is a patient of mine, and this is before surgery, and this is her 1 week after surgery. And you can see their drain is still in place, actually. But she's really, in terms of finished having her mastectomy, she wakes up like this, and she's on her way again. The direct implant route is a very exciting thing. The thing to know also, though, is it's not for everyone. And so women who have larger breasts would not necessarily be a candidate for direct implant placement because it means putting in a heavier implant, and that puts more stress on the skin right after the mastectomy. So for larger breasted women, it just simply may not be safe to perform a direct implant placement. For women for whom it's necessary to remove the nipple areola area, then that may be taking too much skin away, and so we actually need the tissue expander to help expand the skin. And then for women who have had direct implant placement, we still see that about a third of them will still have some other procedure performed at some point to finalize the results of their surgery. So they may have avoided the tissue expander, but they still may have another surgery, and so that's just another important consideration. But for patients who are good candidates for direct implant, it's really a very exciting thing. And here's just another example of a patient who's had direct implant placement. And the key thing being is relatively small breasts with the nipples already not in a drooping position, so they stay in one spot. So just finally, a couple of words about the latissimus flap reconstruction. This is talking about combining implant reconstruction with using your own tissue. And here what we see is it's taking the tissue from the back. So this is your latissimus muscle. This is the skin overlying it, and the tissue is transferred around here. So this is the skin here, and then what we'll do is put either a tissue expander initially or the implant behind there, stretch up the skin, and then that's the results of the reconstruction. When do we do that? This is really latissimus flap reconstruction. Certainly at Sloan Kettering and I think and in most centers in North America, latissimus flap reconstruction is used primarily in women who've had radiation, and we're concerned that the radiated skin might be too thin or might not stretch. And so in that setting, it often gives better results than implant reconstruction alone. Essentially, it replaces that damaged tissue, or in patients who are too slender to have a tissue reconstruction using the lower abdominal tissue. I would say in other centers in Europe, latissimus flap reconstruction actually is used very commonly as the go-to approach for reconstruction. We haven't adopted that quite to the same extent, and the main issue in terms of disadvantages is it's a scar on the back. And some women will also complain of back tenderness or a little bit longer recovery time than they would have if they were having reconstruction with implants alone. So that's a discussion to have on a one-on-one basis with your surgeon. So I'd like to just wrap up with some comments about some of the exciting things that we've been doing at Sloan Kettering. One of the things that we've been very keen to understand better is what our patients think of the results of reconstruction, and then be able to share that information with other patients as they move through the process. And so a number of years ago, we developed the BreastQ questionnaire. We had help from over 2,000 patients when we developed this questionnaire, and now over 15,000 patients have completed the BreastQ, both at Memorial, all over North America, and around the world. And so it's really helping us as surgeons and our clinical teams better understand the experience and the outcomes of breast reconstruction, and that's one of the things that we do clinically with patients, and we also then are able to share with you what other women just like you have experienced as they've moved through the breast cancer and breast reconstruction journey. And so at Memorial, all of our patients are introduced to the BreastQ system when they're first seen. They're told about this, and they're invited to complete the questionnaire online, or they can do it on paper pencil if they prefer. And what this provides, though, is a profile for each individual patient that I see. And I'll just show you an example of a report that I would see. The BreastQ looks at all kinds of different aspects, like satisfaction with your breasts, looks at psychosocial, sexual well-being, your physical well-being. I'm just going to give you a blow-up of one of these different little charts. And so physical well-being, this is a woman who's had tram flap reconstruction. And this is, you can see before her surgery, She started in here. All these are on a 0 to 100. She started at 90, and as she completed her rescue over time, I was able to watch her recovery. Now, and I'm also able to watch to see what fits in that band of normal recovery, and I can identify other women who might be struggling more and might benefit, say, from physical therapy or other treatments. So this is really helping us at Memorial to better understand individual patient needs and make sure that there's not something that we're missing. It prompts a conversation so that women can really share how they're feeling with us and how they're recovering. It also helps in research studies. It helps us better understand how patients overall are doing, and so researchers all around the world are using the rescue and helping us to better understand outcomes. And so this is an example of just one study. This was done at the University of Michigan. And so, as I said, the rescue looks at patient satisfaction with their breasts. And so in this study, they looked at patient satisfaction comparing your own tissue, tram flap reconstruction, with implant reconstruction. And they asked women at these different time points. So these are women that, say a woman who was at 2 years out, another woman who might have been 11 years out, different time points, how satisfied they were with the results of their breast reconstruction. And what we see here is this is implant reconstruction over time, and this is using your own tissue over time. Early on, it's very similar. But over time, what we see, and this is what I've alluded to, is that over time, particularly women who've had one breast reconstruction with an implant and kept their other breast, what we see sometimes is their satisfaction with their breast starts to fall off. And it's a natural process in the sense that women's bodies changes, the other breast may change, their weight may change, and so this is what we see with implant reconstruction. It doesn't mean that implant reconstruction isn't a great choice, but this is the kind of information that we're now helping women to better understand when they're making their decision. And so if you choose implant reconstruction, my patients will understand that maybe at 3 and 5 years or 10 years out, we'll reassess and we'll consider that we might need to do another procedure to help bring the symmetry back up to the levels that we had initially. So I'm going to take questions right now, but I just leave the thoughts really is that I think that one of the main benefits to breast reconstruction is getting back to normal, is to feeling like other women. It's just putting the experience of breast cancer behind you, and I think it's an important option for women. It doesn't mean that all women should have breast reconstruction, and nothing that I'm talking about tonight says that there's any one method that is really the right option, the single best option for women, but options are good for all women, and understanding your options is really the key thing. So I'm going to transition now into answering some of your questions. We've had some fantastic questions forwarded to us, and we'll be also receiving additional questions now as we're moving through the webinar. The first range of questions we're talking, a number of patients asked about the timing of reconstruction, which I've talked a little bit about already. And so, a patient in Weldon, California asked, she said, I'm 65, I had a mastectomy in 2006, and is it too late to have reconstruction? I didn't have it be done before. And so my answer there would be, no, it's not too late. Maybe previously we may have said those kinds of things 10, 15 years ago, but really right now almost all women are candidates for some form of reconstruction. Another patient, also a breast cancer survivor, who's been cancer-free for 17 years in Indiana. She had a mastectomy again with no reconstruction. At that time, she was told that her skin was very thin and she wouldn't be a candidate for reconstruction. And again, she's asking, is she potentially still a candidate? And again, I would say possibly yes. And the message to you I would leave is that a lot of things have changed in breast reconstruction. We're doing things differently. We have new techniques. And so patients who might previously not been considered candidates for reconstruction or not considered candidates for immediate reconstruction, that those things may have changed. And so I would really encourage any of you with these kinds of questions to seek further advice and consultation with your plastic surgeon. Another question was, what factors, this is from Chicago, Illinois, what factors or situations prohibit or delay reconstruction? And so there are some cases that we will still delay reconstruction here. So just in general terms, at Memorial, about 95% of our patients will have immediate reconstruction, but there is a small minority that will have delayed reconstruction. And the most common scenario with that would be a patient who, because of the disease characteristics, we want to make sure that that all the other treatments that she needs to make sure the cancer doesn't come back, that she gets those immediately without any delay whatsoever. And so she will have a mastectomy, and she may then have her radiation of the mastectomy area without reconstruction and chemotherapy. And one of the reasons that we may delay reconstruction also, if she's someone who really wants to use her own tissue, we know that radiation can also shrink that tissue. So we may avoid using her own tissue initially, keep it out of harm's way, keep it away from the radiation, and then after, when the radiation is over and she's recovered, say 6 months to a year later, then we will come back and do the reconstruction at that point. That said, even patients who are in that scenario, who've been told that they most certainly will require radiation, may still be candidates to have a tissue expander placed, and then that tissue expander can be radiated. Now, there's some additional questions that I'll answer as well regarding radiation, but I think those are the issues around timing, is that more and more women are candidates for immediate reconstruction, and there are fewer and fewer obstacles to that. So the next round of questions relate to options and what are the various options and what are the best options. A New York patient has asked us that she was small-breasted and she was always interested in adding a little more volume to both breasts after a single mastectomy, and what are the upsides and downsides of doing this, and will it affect the ability to monitor the breast, the health of the other breast? It's an excellent question. I think as you see in some of these photos, that's a very common scenario. A small-breasted woman, she may be having both breasts. Either she'll have one breast removed and she'd like to have augmentation of the other breast, and this is something that we do very commonly. And it's certainly an option, and it also improves the symmetry in implant reconstruction because it gives that fullness on both sides. In terms of monitoring, as we've evolved in our approaches to monitoring and ultrasounds and MRI evaluations, that's become less and less of a concern. So traditionally, when mammography was the main approach to monitoring the other breast, then in some patients we wouldn't be able to see the entire breast. But now with the different approaches to imaging, I think it's a very safe thing that can be done, is to have an augmentation of the other breast. Note also that the implant for augmentation will be placed deep behind the breast and under the pectoralis muscle, so it's really separated off from the breast, and so that as well makes it a safe procedure to do. Here's a patient who asked about, she was diagnosed with DCIS, and has a strong family history, and so she's having bilateral mastectomies, and she's again wondering about the options of timing reconstruction surgery later or at the same time. And so I would say for women who are having prophylactic surgery, meaning surgery when they don't have an actual cancer, or they have DCIS being a very early form of a cancer, then in that patient population, certainly at Sloan Kettering, almost all of those patients would be offered immediate reconstruction, and there's lots of benefits here. Those patients are not going to be receiving chemotherapy, they're not going to be receiving radiation, and so immediate reconstruction really makes a lot of sense. A patient in Los Angeles has asked us about the possibility of having implants placed right at the same time as the mastectomy, and so this is, as I've discussed, this is what we call direct-to-implant placement. She's having prophylactic bilateral mastectomies, and the question, she says, she's 52 years old, and her oncologist has recommended prophylactic bilateral mastectomies. She's too slender to have the deep or tram flap reconstruction, and she's leaning towards smaller implants. So the question is, can she have immediate implant placement following mastectomy? This is a patient who sounds like an ideal candidate for direct implant placement. She doesn't want large breasts, so I'm not worried about the implants being too heavy and putting too much stress on the mastectomy skin flaps. I also know that she's having both breasts removed, so we'll get good symmetry with our breast implants. So this is something that she would be an ideal candidate for that. And her question is, she's not very happy about the possibility of expanders, and I think that is the nice thing with direct implant placement, is avoiding the tissue expanders. Patients tolerate tissue expanders very well, but I think the tissue expanders are, to some extent, they're uncomfortable. They feel hard. They don't feel like the final product, which is a nice soft breast when we put implants in. A patient in Connecticut has asked what my opinion is regarding nipple sparing, and so my thoughts here is that this is a discussion not just with your plastic surgeon, but also with your oncologic surgeon. So to be a candidate for nipple sparing mastectomy, you have to be a candidate from a cancer perspective, so it has to be safe from an oncologic perspective. So the breast cancer surgeons that I work with, we have a conversation about this every time, and so they'll let me know whether they feel that a patient is a good candidate for nipple sparing from a cancer perspective, which basically means either it's a patient who is having prophylactic surgery, so doesn't actually have cancer, or it's a small cancer, or it's a cancer that's quite a ways away from the nipple areola area. So that's the first part of it. The second part is whether a patient is a good candidate from a cosmetic perspective, aesthetically. So an ideal candidate, as you've seen some of these pictures, an ideal candidate for a nipple-sparing mastectomy would be a patient who has small breasts and there's really almost no droop to the breast because the nipples sort of stay right where you want them to be. A patient who would not be an ideal candidate would be a patient that has a little more droop to the breast, so perhaps an older woman where the breast naturally has come down, or a large-breasted women. And the reason for that is that we can't. The position of the nipple is not as fixed, and so that can result in the nipple areola area looking too far off to the side, or the two sides looking different. And so for some patients, although they may be from a cancer perspective, a nipple-sparing mastectomy may be an option, it really still may not be the best thing aesthetically. So that's a discussion that for every patient that I see, that's something that we talk about. The next series of questions asked about fat grafting. I think fat grafting is a very exciting thing that's happened, and sort of some of these exciting things that we're hearing about direct-to-implant and fat grafting being one of them. So we do a lot of fat grafting at Sloan Kettering now, and I think some of the greatest benefits are in a patient who's had a mastectomy, having implant reconstruction, and sometimes we can either see or feel some of the wrinkles of the implant just under the skin or just under the muscle in this area. This particular area of the chest is really important to women because it's what people see when we're wearing our bathing suits, our bras, or lower cut tops. And so this is the area that we're most commonly starting to fat graft, essentially to kind of camouflage the underlying implant, and it's giving really some beautiful results. So fat grafting is something that I would definitely, if there's to ask your plastic surgeon about it, that's something that you might benefit from. Many women may not need fat grafting, but for some women it's really a great thing. We're also doing, in some women who may have used their own tissue, even fat grafting, to increase the size of a tissue transfer. So in a slender woman, she doesn't have quite enough tummy fat, we do the reconstruction. We still want to make it a little bit bigger. I may come back a few months later and add a little bit of fat from her hips or from the thigh area. So it's really helping us to offer more and more to our patients. The thing also to know about fat grafting, though, is the technique is evolving. It's a newer thing, so we don't generally get 100% take of the fat graft. So a patient that I put in the operating room, I put a certain amount of fat in, I may see that 10, 20, or even 30% of the fat resorbs, meaning it essentially kind of dissolves, and that we may need to come back and do more fat grafting, or we might just anticipate that this may be the case. Here's a question. Would you recommend fat grafting as part of the reconstructive journey for BRCA patients, and are there any oncologic safety issues? And also an excellent question. There's been a number of studies that have been performed looking at the safety of fat grafting, and there's no one definitive study that has said 100% in terms of is it an issue in terms of either increasing the risk of cancer recurrence or making it more difficult to watch for a cancer that may evolve. But this is something clearly we take very seriously at Sloan Kettering, and so we've been watching how this discussion has progressed, and what we're seeing is an increasing number of studies that are really conveying the safety of fat grafting. Another question here from Connecticut. Can you discuss the differences between different types of implants? And so look at round, smooth, textured, saline, silicone. I think this is actually the most common question that when in patients who are having implant reconstruction, so what type of implant is best for me, doctor? And the way I answer this really is to go back to our breast-Q data. So the very first question would be, so a saline or a water-filled implant or a silicone implant? And so this would be this is a question that all women would face. And so you could say, well, a silicone implant, as I've said, it needs to be probably changed maybe every 10 years, maybe not quite every 10 years, maybe a little bit longer down the road, but there's more of a maintenance component, where a saline implant, if it leaks, it only gets removed if it leaks. Otherwise, we don't change it as a maintenance. And so that's a benefit to saline. But what we hear from patients, though, and this is our breast-Q data, is that patient satisfaction, that breast-Q score that I've shown you, the same kind of data when we look at saline compared to silicone, is that what women are telling us is that silicone looks and feels better. It feels more natural. It feels more like a breast. So hence, for women who ask those questions, then we would generally encourage them to have a silicone implant. Doesn't mean all women should have silicone implants. As the other side of it, because say in an older woman, she may say, I'm 60 years old now, I don't want to be worrying about this in 10 years time. And so that's a discussion that we would have. There's lots of different types and shapes of implants out there now. In general, though, I would consider that there's some pros and cons, and I would caution women to get too caught up in what may be marketing by some of the implant companies. One of the the downsides to some of the newer teardrop implants is that they may feel firmer than a natural breast, and there is also potential for them to move and to shift in a different position, whereas a round implant, if it shifts, it will you would never know. It looks exactly as it was always in the same place, whereas a shaped implant can occasionally move and change, and so that still may be the right choice for a patient, but it may add an extra factor for other women who are looking at their decision making. In general, the shaped implants and the firmer, the more cohesive gel implants are great for patients who are very slender and the implant is right under the skin. But for a lot of other patients who want a softer or more natural feeling breast, some of the more traditional softer implants are a great choice. And then if we see some wrinkling or some rippling of the implants, then now we'll fat graft over top. There's some questions also tonight about radiation, and so the radiation is a very important topic, and what we're seeing is that more and more women are being offered radiation after the mastectomy, and so they may be offered it because of tumor characteristics or different issues that will help to decrease the chances that the cancer would come back into that area. But it's an important consideration as women are also trying to chart their path through reconstruction, and just in very general terms, radiation of an implant can increase the chances of scar tissue forming, so the capsular contracture, and in general terms, radiation of a reconstruction using your own tissue can cause a shrinkage, can cause that breast that we've made to get smaller over time. So that's really, those are the main downsides to radiation for reconstruction. Clearly, though, if it's something that's of value from a cancer perspective, then we look at both sides of that equation, and safety and making sure the cancer doesn't come back being the first priority. The question here was, when a patient needs radiation, this is from San Mateo, California, when a patient needs radiation, do you suggest doing the implants before or after radiation? So first part, if a patient's having a mastectomy, do we recommend having implants before or after? There's different schools of thought on this. Our approach at Sloan Kettering is if I know for sure that a woman is going to have radiation after the mastectomy, then I would generally recommend we can still put the tissue expander in. We'll do the expansion. We'll actually do the exchange procedure, put the permanent implant in, and then radiation would happen last in the sequence. And generally in that same patient, chemotherapy would happen in the middle of there while she's going through the process of the tissue expansion. So, and the reason we do that is in the sense that then the surgery to remove the tissue expander and put in the implant in is done before patients had radiation, so we don't deal with the increased operative risks of radiated tissue. Meaning that there's an increased risk of infection or increased risk of having problems with wound healing after patients have had radiation, and so that's our general approach. But some patients will, if we're particularly concerned about the risk of cancer recurrence, then those patients we will counsel to actually have the tissue expander placed. They'll have their expansion, and then radiation will be performed with the tissue expander in place. The positive being that delivers the radiation more quickly. The negative being is that then we need to leave that tissue expander in for longer, up to 6 months, to allow the radiation changes to settle, to make it safe to then operate on that reconstructed breast. A question here is, what are the advantages and disadvantages of having deep flap or autologous tissue transfer after radiation therapy? This is really the group that's had radiation in the past is really the group that does spectacularly well using their own tissue, because then we don't have to worry about the potential for scar tissue forming after implant placement. In general, just in basic terms, if you think a woman who hasn't had radiation, her risk of developing scar tissue around the implants may be in the range of about 10%. And a patient who's had radiation, that risk moves out to in the 30% range. But that 30% range is a spectrum, so you can have scar tissue that's quite subtle, but you can have scar tissue that forms that actually can be uncomfortable, can be painful, can cause limitations in physical mobility even. So in that 30% of patients that may have scar tissue, that's the range. It would still be a minority that would have more severe symptoms, but it's for those patients that we generally recommend autologous reconstruction. And I also have patients in my own practice that at the time that they were going through the process of having their mastectomy and their cancer treatment, they opted to have implant reconstruction as a shorter surgery, as less recovery, and to just be able to move through the phases of breast cancer breast cancer treatment. And then later, if they've had issues with scar tissue forming, maybe even 5-10 years later, then at that point they would have the implant removed. Instead of removing it and replacing it with a new implant after removing the scar tissue, they actually just remove the implant and we do reconstruction using their own tissue at that point. So in this whole spectrum of the different options over time, that would be one of the ways that we would essentially kind of start the clock again, getting rid of all that radiated tissue and putting a woman's own tissue in. Another question about radiation. What are the positives of what's the position on, this is from Cancer Connect, what's your position on reconstruction post-radiation and a woman who's had a total mastectomy, very thin chest, and does not have enough tummy fat for using her own tissue? So in general, this would be the patient that I think would be an excellent candidate for perhaps using the combination of using an implant and her own tissue, so the latissimus dorsi flap. So that slender patient, maybe previously radiation, perhaps a patient who had a cancer many years ago and was treated with a lumpectomy and radiation, so breast conserving therapy, and then 5-10 years later has developed a new cancer in that breast, or recurrence of cancer in that breast, but slender. That would be the patient that I would then recommend latissimus dorsi flap reconstructions. We would remove the radiated tissue, and we would reconstruct with the tissue that's not radiated from the back area. Another patient that said, how often should I see my plastic surgeon after the implants are in? I think that does vary from different practice, and it depends on what type of implants you've had, and depends on whether you've had radiation or not. In general terms, after a patient gets through the acute phase of all the surgeries and this kind of thing, then I'll see my patients on an annual basis. Some patients, if you've had a saline implant reconstruction, then I may see her every 2 or even 3 years if there aren't any issues. But silicone implants should have some level of surveillance, and so at least at a minimum, maybe every 2 years. But most of our patients we would see on an annual basis, certainly in the first 5 to 10 years, to make sure there aren't any issues. We had some excellent questions about insurance coverage and what is covered and what isn't. And I don't profess to be an expert in insurance, but I do understand what women's rights are in terms of what is federal legislation about rights of having reconstruction after mastectomy surgery. So in general, if your mastectomy is covered, then there is federal legislation in place that covers reconstruction. Similarly, and this is an important point, is that women who've had a mastectomy on one side and reconstruction of that breast, there's also legislation that confirms that women should then be entitled to surgery on the other breast to help it match. And so you've seen a lot of our pictures that a woman may have had a reconstruction using her own tissue on one side and then had a reduction on the other side, then that's a patient that would be covered, that should be covered by insurance. Similarly, all the different phases of reconstruction, so nipple reconstruction, those things over time, and then any issues over time would also should be considered reconstructive and should be covered by insurance. So other procedures, say augmentation of the other breast, that wouldn't be considered that wouldn't and shouldn't be considered a cosmetic procedure. That would be considered part of the reconstruction, is to augment the other breast to help it match the side that's had the mastectomy and the implant reconstruction. Along those same lines, some women may have not had reconstruction initially. They may have had a mastectomy alone, and then over time, and they may not even desire reconstruction. But over time, that other breast, if it's gotten larger, it's gotten heavier, and symmetry and discomfort is an issue, then simply that reduction should be covered by insurance to reduce the other breast. They may even in the absence of a reconstruction, say if your left breast you've had a mastectomy, but the right breast over time has become bigger and heavier, some patients will have a reduction to that side just to make it easier to wear a lighter or smaller prosthesis and make that an option. And again, that should be something that is also covered. That's a reconstructive procedure that insurance should cover. Along those lines, actually, another issue that comes up commonly is women who've had lumpectomy surgery, lumpectomy radiation on one breast, and then what can we do to the other side to match? Sometimes after a lumpectomy, not infrequently after a lumpectomy and radiation, the breast will get smaller, partly because we've removed tissue, and then also partly because the radiation may shrink it over time. And that may not be apparent initially. It may become apparent gradually over time. And so in those patients, they may benefit from having a reduction on the other side. And so those patients would then similarly, what we call, it's called a symmetrizing procedure, all of those other procedures that are performed on the other breast. And so it's common that patients will ask me if this would be considered cosmetic or not. And the answer is that it should not be considered cosmetic, even though the surgery is happening on the breast that did not have cancer. So finally, we've had some questions regarding tattoos and nipple reconstruction and who's the candidate for this. I think that the issues around, so this is in a patient population, thinking of patients that are not having a nipple sparing, but in a traditional mastectomy where the incision removes the nipple in the areola and then it's closed in the line. And so generally about 3 months or later after the placement of implants or the reconstruction with our own tissue, we'll come back and talk and discuss the option of nipple areola reconstruction and then possibly tattooing. So the options are a woman could just have a tattoo, simply a tattoo, and that can be, we can vary the color enough to give it a bit of a sense of a 3D, but it really is, it's a tattoo. It's a relatively flat construct. But many women would also choose for us to first make the nipple so it has a little bit of projection, and the areola we will often do with the skin graft to give it also a little more of a texture, and then the tattooing would happen after the nipple areola reconstruction. So either a single stage with just the nipple, or a single stage with just the tattoo, or we do the nipple and areola reconstruction and then tattoo after that. And so in terms of who are candidates, who's a candidate, who's not a candidate for that, almost all women will be candidates for a tattoo. It would only be in a patient who's had extremely thin skin that's been perhaps radiated and has had poor quality skin and perhaps maybe some previous infections that might not be a candidate. But again, most women would be a candidate for a tattoo. Our tattooing techniques have gotten better over time. The machines have become increasingly gentle and the healing time is shortened. So I would encourage women to consider that as an option. And then the options of nipple areola reconstruction, women who are smokers or heavily radiated may not be the best candidates for nipple reconstruction and might be encouraged to just have a tattoo. But for most other women, they would be considered candidates for some approach to nipple reconstruction. And I think that for many women, again, what I hear from patients and what we see with BreastQ data is that that's that last step in the process. That's closure. It really helps to normalize. It helps to make it a breast. And so the BreastQ research that we've seen now with a recent study showing that women they report better sexual well-being, psychosocial well-being, better body image when the nipple reconstruction is done. Keep in mind that though that the nipple reconstruction doesn't have, we don't as yet have an approach to achieve sensation in nipple reconstruction. That's something that's being worked on. And even with a nipple sparing mastectomy, unfortunately women still lose a lot of the sensation to the nipple areola area. But in terms of the aesthetics and in terms of how they see themselves and how they feel about their bodies, I think nipple and areola reconstruction or tattooing alone has some very significant advantages. So final questions this evening, I think, are just issues around different types of implants and also just sort of there's issues around the approach to reconstruction in women who may have autoimmune disorders or have concerns about that. And I think I would generally ask that you take that back to your specific team, to you talk to your, it's a very much an individual question. But going back to the issues around silicone, to a large extent, and for most patients, we really put that to rest. And so I think women should feel that having a silicone implant at the present time is a safe thing to do. And as we've seen with our BreastQ data, that it has some very significant advantages over a saline implant. And so when placed appropriately and when followed appropriately, that it's an excellent and can be a very safe option. We had some great questions this evening, and unfortunately I haven't been able to answer all of them. I think if anyone has additional questions, new questions or questions that we weren't able to answer this evening, then I would very much encourage you to go to our MSK website. We have some excellent educational materials that are available there, or to make an appointment to come and see any of us. We're an excellent group and with a very broad experience in breast reconstruction techniques. So I appreciate your questions and your attention, and I wish you a good evening. Thank you.
This concludes today's program on making informed decisions about reconstruction after breast cancer surgery. I want to thank you again for participating, and many thanks to Dr. Pusic and Memorial Sloan Kettering Cancer Center for making this web chat possible. This program will be available on our on-demand section here on Cancer Connect so that you can visit it again or share it with others who may benefit. Thank you.